For more on the coronavirus pandemic in South Africa, we look at this. You remember that the first months of it, the World Health Organization had warned that Africa's health systems would struggle to cope if the virus began to spread on the continent. That prediction is being realized. Africa has now passed the 1 million mark and accounts for 5% of the worldwide cases. South Africa accounting for 2/3 with a cumulative of 538,184 cases, 9,604 deaths. To speak more about this, Professor Salim Abdool Karim, Chairperson of the COVID-19 Ministerial Advisory Committee. A very good evening to you. Good to chat to you once again, Professor. So I think the most important question to ask now is, has South Africa really passed its peak now that we're seeing a decline in the reported numbers of recent cases?
A very good evening, Sabiso. If we look at the situation over the last 2 weeks, we have seen a decline in the number of cases. And if you look at a 7-day moving average, you can see that it's been pretty consistent over this last 7 to 10 days. However, those are still very early days because we still have each day, several thousand new cases. Right now, the decline that we're seeing is driven largely by the decline in Gauteng. But at the same time, the number of cases in KwaZulu-Natal are steadily going up. So we're not sure if KwaZulu-Natal has sort of reached a point of plateau. Is it going down, going up? It's not very clear. So if KwaZulu-Natal continues to go up, we will start seeing our numbers of cases also going up as a national level. So it is too early to tell.
And that's what I'm interested in, Professor Karim. There's a lag in testing, which the minister has spoken about, asking the National Health Laboratory Services to see if it can buck up. So will additional data confirm that indeed, for instance, the Western Cape, the Eastern Cape and Gauteng have seen a downward trend in the cases?
Yeah, so what I've been told by the National Health Laboratory Services is that they have no backlogs in the other provinces. The only backlogs that exist are in KwaZulu-Natal, which they thought would be completed by the end of this week, and a small backlog in Mpumalanga. So what we are seeing are the real-time numbers. We may see a bump, which might be today or tomorrow, that will come as a result of the backlog in KwaZulu-Natal. But the other numbers have no backlogs. They just reflect the available testing that has been done.
What about the issue of excess deaths and the uncertainty over what that really means?
So we've seen this across the board in many countries, that during the period of the surge, the number of cases, the number of deaths rises quite rapidly. And most of the healthcare services don't really cope with reporting of the deaths during that period. Sometimes they make it up, sometimes they will only make it up partially. In South Africa, we seem to have an underreporting of deaths during that surge period. And if we look at the excess deaths over what was expected historically, it looks like our undercount is somewhere in the region of around half. So we will hope that there will be a catch-up after this lag during the surge, but what's not caught up, we'll have to adjust for that, like was done, as was done in the UK and other places.
And I want to talk about what may some say be a future surge, as in that we're likely to see a surge further down the line with much higher levels. And I wonder, Prof, if the National Health Council agreeing to change testing of people who have already passed on, if that will also alter the numbers.
Yeah, we would expect that will give us a better idea of the deaths that are due to COVID, because the current reporting is largely hospital-based. So we're missing out on those who die before they get to a hospital. And so this will help us in getting a clearer idea of the number of deaths. But I think there's a very fundamental issue you're raising. I mean, if you want to know, what keeps me up at night, I'm really concerned that we have to do everything we can to avoid a second surge. We saw this in the US. They hit a peak and then they started coming down. The cases were coming down quite nicely. And then suddenly, as they eased restrictions, it went back up and it skyrocketed. And I've seen this now in a few countries, and that's a scary thing to see because it can get very rapidly out of control. So it's going to be critically important. We are at a critical stage. We can't be complacent, and we can't think that we've won this battle.
We'll talk about testing for an accurate picture of our epidemiological status in just a moment, but I want us to use Western Cape as a case study at the moment. So originally it was forecast to peak in August, but that saw the epidemic peak a little bit sooner, late July. What was the reason behind that? And I know our model keeps on changing for various reasons. So can you just bring us up to speed on what we're considering and why we are where we are now?
Oh, you're raising a sore point, Sipiso, because when the minister asked me in March, how is this epidemic going to unfold? I said to him, it's going to start in Gauteng. Gauteng has, the largest number of travelers. It's got an international airport. It's got, 15 million people living in this density. Expect Gauteng to really start. I was wrong. Instead, it started in the Western Cape. We don't fully understand why, but one of the things became very obvious was that at the tail end of restrictions, we started seeing outbreaks in the grocery stores and the supermarkets, the Khayelitsha Spa and so on, in the Woolworths. Those became the spark that then seeded the virus in the community. And so the Western Cape took off much earlier than any of us expected. And I think we'll begin to understand more about the epidemiology and how it spread, but one of the key things seems to be these events where you get the super spreading occur. And we've now seen 2 studies that have looked at this issue, and they can show that small numbers of people can account for a large number of the new cases.
So we'll move on to Gauteng in just a moment, but a doctor in Khayelitsha working there said the most important lesson that they learned is that reactivity is key. So explain to us in layman's term, what exactly does that mean and what can other provinces do?
So I think one of the things that the Western Cape did quite well was that they looked at their data by sub-district. And then they went in and they identified the hotspots. And once they identified the hotspots, they tried to understand what was the source of the spreading in the hotspots. And once you understand that, then you can start trying to slow the spread of the virus. And so that probably helped them in reducing their peak. So they didn't have as high a peak as they would have otherwise have had. And that strategy is being used now in a few other provinces. But what's central to it is that you react as the fires start. As you see the little flames, you go in and deal with them before it becomes, just an uncontrollable fire.
So is it more about a targeted response system or approach? I mean, if we're looking at, for instance, oxygen, it's been said that instead of investing in costly ICU facilities, if you go more to a community-based approach that ensures immediate care, that you're better off. And I'm wondering, would this help Gauteng, which is seeing something like 6,000 cases per day, and that seems to be rising, flattening in some cases. We heard the Premier talk about, I think it was Soweto, some parts of Joburg, Mayfair, Ivory Park and Midrand. So would that kind of approach help in these instances?
Each area has different challenges and different needs. And if I've learned anything in this epidemic, it's that, what you learn, you must learn as a principle, not try to just copy it.
Okay.
You have to adapt it and use it for what you need. If we look at the Western Cape, because they went very early in the epidemic, we didn't fully understand how the oxygen needs and so on would take place. But they showed us that they put these high-flow nasal cannula, and that way they prevented or avoided several patients having to be intubated. and ventilated. So we are learning as we're going along, and that's part of the reason why we have a lower case fatality rate, because we are learning and we're doing better. As we go along, we're doing better and saving more lives.
Our testing capacity and accuracy, Professor Karim, where would you put it, and what would we need to improve, especially given the fact that there is also a shortage of testing kits?
Yeah, I think the testing that we are doing in this country comprises both the public and private sectors. And when we look at, particularly in the public sector, it's been a case of we've done well at times and we've done not so well at times. And initially, we really did not test enough. We should have done a lot more testing. The problem was we weren't sure if we could get hold of the kids. And as a result, we had quite stringent requirements to be tested. But then as we eased that, we were able to scale up testing. When we scaled up the testing, we couldn't get enough kits. Now we can get enough kits, but we're dealing with the surge. So I would like to see us scale up our testing in a much, much more dramatic way once we are now over the burden of what's required at the hospitals. If we can get hold of the kids, we need to have a better strategy to identify the hotspots, to go into each sub-district, to know where cases are occurring, and to deal with them before they start spreading.
Professor, thank you so much. Always good to speak to you here and get your insights on COVID-19 situation here in South Africa. Professor Salim Abdool Karim, Chairperson of the COVID-19 Ministerial Advisory Committee, thank you very much. The Special Investigating Unit has identified